All right, so glaucoma. Okay, so glaucoma has to do with aqueous humor, not vitreous humor, but aqueous humor. Aqueous is aqua-like, water-like. Okay, so that's hypertension of the eyeball, basically. We got increased pressure inside the eyeball itself. The aqueous humor cannot get reabsorbed. There's a blockage of some sort. It could be a blockage that's genetic, meaning that they have a closed angle, an angle closure glaucoma. Luckily, it's rare, but that's where the eyeball is super tight right here. So you see the cornea and the ciliary muscle in the iris right here, and the ciliary muscles make a super tight angle, making it difficult for the aqueous humor to get reabsorbed. But where does aqueous humor get reabsorbed? So it gets made back here behind the pupil, all right, behind the iris. That's where it gets made, and then it has to do a little travel, a little journey. So it gets made back behind here, behind the lens, behind the pupil, behind the ciliary bodies, right? And then it gets made, and then it makes this journey all the way to Mordor even, right? And it gets reabsorbed in two different spots, okay? So those two spots, obviously, our medications are going to work on. They are going to open them up. Also, we have medications that are going to stop the production of aqueous humor down here, right? So we're going to stop the production of aqueous humor. So that's the problem. The problem is the aqueous humor is being made. It's not usually too much being made. It's usually a problem with the reabsorption because it gets reabsorbed down here into the lymph vessels and into the venous system and then back into circulation, right? And the other way it gets reabsorbed is via this little pathway that also gets down to the vein system. Okay, those two pathways are called the trabecular meshwork. All right, so it's a meshwork of muscles, right? And the canal of Schlemm is what the main canal there that everything's trying to be drained into, right? And that's about 80% of our flow of aqueous humor that we want to operate on. And the other about 20 to 40% is our uveoscleral network. That's up top. Sorry, right back at the bottom here, via the ciliary body. Remember, our ciliary body is when it's relaxed, right? When our sphincter is relaxed, it's all the way dilated, right? And you can think of it as like a whole bunch of blankets, right? And all the blankets are laid down, and they're all, when our pupil is dilated, for instance, all these blankets are dilated down, right? It's like a huge amount of blankets that are all pushing down on that uveoscleral network, making it difficult for fluid to get through. But when our pupils were to constrict, right, our ciliary bodies were to contract, that would alleviate all of that pressure and allow the drainage of the aqueous humor. So, do we want pupils to be dilated or constricted for glaucoma? When our pupils are dilated, right, that means our ciliary muscles are relaxed, right? And we have all this relaxed ciliary muscles all piled onto that uveoscleral network, making it difficult to get fluid through, right? So does that mean we want pupils dilated or constricted? You want them constricted because if pupils are dilated, that's going to make it difficult to get fluid out of the eye, the aqueous humor out of the eye, normally, right? Especially with someone with glaucoma, or that's where it becomes a problem. Okay, so that means you want to encourage SNS agents or discourage SNS agents? No. If you encourage SNS agents, the SNS pupil dilates, right? So we don't want to have sympathomimetics or SNS agents, right? Would you want to give atropine to these people? What does atropine do? It's anticholinergic, right? So it means it's going to stop acetylcholine, which is parasympathetic, and parasympathetic is what we want. Parasympathetic is what pupil constricts. So giving something that stops that, pupil dilates, and that'd be contraindication. Okay, so that's the medication part, all right? What are the things we talked about here? So intraocular pressure, what is too high? Greater than 21. We can measure that with a tonometer, or via tonometry, to measure the pressure of the eyes. They put a little puff of air, and they're able to measure how much pressure is in the eye. And if it's more than 21, that is considered high intraocular pressure, and it could be glaucoma. Okay, there's a chronic condition that people live with, so it's not something that you're like, oh, I fixed my glaucoma. No, you're on these medications for life. Okay. So what else on that? That's how it works. Is there's that these two networks are compromised in some fashion, right? It could be the rare situation where the network itself is just squished to begin with, right? So here is closed angle glaucoma, right? Atropine being contraindicated, right? And that angle's close is narrowed to begin with, and that is like a genetic situation, okay? Or maybe they had like trauma that put them in that situation, right? But open angle glaucoma is the more common one, and that's where the canal of Schlemm or the uveoscleral network is not able to drain as efficiently as it normally would, and if it can't drain, the fluid backs up, right? And then it's going to increase the intraocular pressure. All right, so what are symptoms of glaucoma? So this one has pain. Is the first one we talked about pain, right? Even retinal detachment didn't hurt unless they had trauma associated with it, right? And that trauma is not because of the retina detaching, the trauma is because of their eyeball around it that got traumatized, right? Refractive errors don't cause pain. None of the things we talked about so far causes pain. So that's a really big differing factor for glaucoma, okay? So acute angle closure, it's always all over the place. It's all over the NCLEX. It's all over everywhere. That is, be aware of that because that it's a sudden onset trigger that puts them over the edge. But it is rare, luckily, right? Because we give atropine to a lot of people. So they're trying to get rid of it, but it's still a lot of cardiac arrest and such, right? Anyways, we are losing peripheral vision. So you can imagine if your pressure is increasing, it's putting more pressure on the sides here, right? You can imagine the retinas on the sides starting to fail first, right? So that's going to put this peripheral vision loss is a unique finding with glaucoma, right? They got the pain, and it's not curtains, right, from left to right where it's detached and that retina has fallen on your vision, right? In this case, it's the pressure that's causing the rods and cones to literally start having dysfunction and therefore blindness, right? So they might have some rainbows around lights, some halos around lights, just like our patients with astigmatism. But they're going to have some blurred vision too because it's not working good, and that leads to some nausea, vomiting, headache. So we'll try some medications to try to fix it. But if medications don't work, which are on the next slide, we have surgical options, and surgery includes just using lasers again, right? Use a laser beam, right? And you're going to just obliterate and open up that canal of Schlemm. You're going to make it a canal, right? If it was just a stream before, you're going to make it a little river so that it can drain the aqueous humor. Okay, that's called a laser trabeculoplasty. And then we can, if that doesn't work, we can literally put a tube behind the eye, right, behind the lens, and thread it to the front so that it drains no matter what, right? Those are little implants they can put for patients with severe glaucoma that doesn't respond to medications. Okay, so that's the idea behind the symptoms for glaucoma. All right, so we have this closure here that's making it difficult to get fluid out, and it backs up, and now all the pressure starts getting higher and higher in the eye, and we get a increased intraocular pressure greater than how much? Greater than 21, and that's going to then cause a compression of the rods and cones and the retina and lead to dysfunction, and that increased pressure is going to cause pain, okay? And their eye will change color like that too. Oh, flash, okay. So glaucoma treatment, all right? It's the first time I use transitions, the whole glaucoma treatment, all right? The goal is to decrease intraocular pressure. And how do you decrease intraocular pressure? Well, you just turn off the hose or the faucet for aqueous humor, right? That makes sense, right? If they have too much aqueous humor that's not getting through, the little canals and trabecular meshworks and uveoscleral pathways are not absorbing the fluids like they should, right? There's two different ways to absorb the fluid back in the bloodstream. Well, why don't we just turn off the hose, right? They agree to. So beta-2 agonists or beta-2 blockers, which one do you think is a good option? If we have a beta-2 agonist, right, we have an agonist, an SNS agonist, is that good? No. So we should not give beta agonists to these patients that have glaucoma. That's going to cause pupil what? Pupil dilation, and that's going to put a whole bunch of pressure, right? It's going to put like you're lying a huge blanket. I tried to find a perfect GIF for this, but I couldn't think of one, right? Like I was trying to think of like a hot air balloon lifting off, right? And when hot air balloon lifts off, that's like your pupils constricting, right? And then your pupils dilate, the hot air balloon deflates, right? And that's going to put all that pressure onto this network down here that makes it difficult to drain, right? So do we want pupil dilation or pupil constriction for these patients? We want pupil constriction, right? So beta blockers, yes, will cause some pupil constriction, which is cool. But really what they're doing is they're going all the way down here to the production network where we produce our aqueous humor. So we're producing aqueous humor down here, AQH, right? We're producing aqueous humor, and beta-2 blockers will stop the production, which is nice, right? We're going to decrease aqueous humor production altogether. Okay. So the other thing we can do is, we decrease aqueous humor production, right? That's produced by the SNS, that's produced by a beta-2 agonist, so we're going to give blockers to block that production, right? So increase aqueous humor outflow. So that means we got to open up the trabecular meshwork or open up this uveoscleral network. We got to open it up, right? Well, you open up the uveoscleral when you pupil constrict, which is nice. And then the other way we can do that is with alpha-2 agonists. So remember, alpha-1 agonists are SNS. Alpha-2 agonists turn off the SNS. So these alpha-2 agonists will open up those venules and open up the waterways so that they can actually drain, like open up the dam so it can drain better, right? So alpha-2 agonists relax those vessels and they relax that meshwork and allow it to drain as much as possible, all right? Also, alpha-2 agonists inhibit the SNS. So that's going to be nice that it causes also pupil what? If you inhibit the SNS. Pupil constriction, right? What's the fancy word for pupil constriction? It's a big word. Small word is pupil. Sorry, so small word is pupil constriction. Big pupil is a mydriasis, right? Mydriasis is a pupil dilation. Meiosis, not the cell division one, but meiosis is pupil constriction. Okay, so increase aqueous humor outflow. So we have the alpha-2 agonists do that, and then also we can contract the ciliary muscles. We can make them squeeze like a sphincter, and that will alleviate the pressure on that network and allow you to drain further. Okay, so what's bad is pupil dilation, right? Big pupils. And what's another word for big pupils is mydriasis, right? So that's not good. Meiosis, that's great, right? We want meiosis, right? We want our pupils to be small or big. Our pupils to be small, right? Pupil constricted. So SNS is not good, and beta-2 agonists are not good. Epinephrine, anticholinergics, which is atropine usually, right? That's going to be what we want to avoid, right? So constriction is great. We want to mimic the what system? Parasympathetic or sympathetic? We want to mimic the parasympathetic. That's a fancy word, parasympathomimetics, right? They mimic the parasympathetic nervous system. They are anticholinergic or cholinergic? They're cholinergic because the parasympathetic uses acetylcholine, right? So ironically, they're not used as much anymore, right? Because they cause pupil constriction, but they have a complication of retinal detachment. So the bad side effects usually makes us shy away from them, right? Prostaglandins are an option to vasodilate that network, but they burn, just like prostaglandins are involved in inflammation. It's like just giving a little dose of inflammation to the eyeball, right? So they inflame as well. You get red eyes, right? You get also a dark iris and thick lashes. I mean, if you want thick lashes, go for it, right? But you have red burning eyes also. It's like, I went through the pain for this beauty. Okay, but yeah, so the other option is carbonic anhydrase inhibitors. So these guys are usually diuretics, right? So we have acetazolamide is usually used as a diuretic for patients, right? For patients that have fluid overload and such. It works the same thing in the kidneys to prevent water production and to allow you to pee out extra fluid. Here is preventing the production of aqueous humor or water, okay? So let's take a break and let's do macular degeneration last. That's our last eye disorder, I believe. All right, so let's resume. So we did refraction errors. What else? Other eye stuff you know about? Glaucoma is down here, right? Guacamole. What else? And cataracts. And between cataracts and glaucoma, we have what? Cataracts. We got retinal detachment, right? Cataract surgery, which is one of the options here, right? So, but cataract surgery is actually one of the causes for retinal detachment, right? So we got glaucoma, and then the last thing we're talking about is macular degeneration. Okay. That's it for eyes. All right. So macular degeneration, that is degeneration of the macula. Any questions? All right. So anyways, where's your macula at?
Back of the eye.
It's the back of the eye. It's not the exact. It's where the most light is focused on the eye. So if you look back here, the most light that comes out of your lens, right? So we go through the lens. Let's make sure I got it selected here. Go through the lens, through the cornea. We're going to hit the macula back there, right? That's the fovea macula. That's where all the light is concentrated. That's where your body makes the most rods and cones. And then off center is your optic disc. That's your optic nerve. So everything filters from all the rods and cones, all comes together like a big networking event. Have you ever seen an IT department? It all then threads into the optic nerve down here, right? So that's the primary central vision. So what kind of vision loss do they get? Central vision loss, right? So most common form of age-related blindness. So with age, you can get macular degeneration, right? It's a consequence of aging, right? What's the most common cause of blindness is cataracts, because you can skip steps to get cataracts, right? You don't have to be old to get cataracts. But cataracts and macular degeneration are the leading causes of blindness, right? So risk factors, we have non-modifiable. You can't modify how old you get just yet, right? So 2% risk with age. If you're greater than 75, you have a 30% risk of getting glaucoma, but getting macular degeneration. Having a family history puts you at risk. And there's some modifiable things you can do that would accelerate your macular degeneration, and that's when you have cardiovascular disease, you have atherosclerosis, you have damage to your macula itself, damage to your retina due to poor perfusion, right? Also poor nutrients. Low zinc is linked, and there's like 5 other nutrients that are also, when they're low, you're high risk for macular degeneration. And one of the treatments we give people, or even non-pharmacological because it's a supplement, it's like not something you have to get a prescription for. You just go to Costco. That's where I got mine. After I did this lecture 3 years ago, I was like, oh, I should take these. And then I stopped taking them 2 years ago. But anyways, they are evidence-based things you can recommend to a patient to prevent the onset of macular degeneration and prevent the progression of blindness, right? So when I start getting blind, I'll start taking them again, all right? They're in my cabinet for a year. Yeah, anyways. So we got central vision loss because the macula is degenerating, okay? How is it degenerating? We have a lot of blood flow to all those rods and cones that are right there in the center, so that's why that's the area that gets the most affected, right? So the cells die right there, and then there's, the body says, you know what, how you can make more, you get more blood flow there, make more blood vessels, right? So they make more blood vessels, and the blood vessels are not blood vessels that you're used to. They're friable vessels that don't make any sense, right? And they are leaky. And it's almost like a retinal detachment situation, right? We're making more and more bleedy vessels that are friable and thin and break apart, right? So it's like I'm helping, right? I'm trying to make more blood vessels, but they actually are not, right? And it leads to what's called, there's early macular degeneration and there's late or wet macular degeneration. So there's dry and wet. So dry is where you're just first off having that lack of flow to the macula, and it starts getting inflammatory there. And then after a while, we start developing this wet macular degeneration, which is the blood supply. It's almost like a hematoma that's forming underneath, and it starts separating the cells, right? The rods and cones from the retina, okay? So that's a problem because now you have this area right here is not going to accept light or photo information because the rods and cones are no longer attached, right? So that's the idea behind macular degeneration. We're at risk for retinal detachment with wet MD. Once it's progressed and further, it can lead to blindness, right? And what specifically is making the vessels go off and make more and more blood vessels? It's called this VEGF factor. It sounds like a meal plan you can buy online on YouTube, right? I just described it VEGF, it makes my life better, right? Anyways, VEGF is vascular endothelial growth factor. So it's a factor that grows endothelial cells, meaning blood vessels. The reason I bring it up is because we have medications that are anti-VEGF, right? These medications are specifically designed to stop that growth of blood vessels, which then leads to the blindness, right? Other important points is we got these drusen bodies, which you can see on when you do an ophthalmologic exam. You look at the retina, you can see these yellowing changes. They can see the red changes, right? So they can see those, and then they can develop into this distorted vision. It's not only at first, eventually it's blindness, but at first you can see how this gets higher and lower, right? So that's exactly what happens to the vision. You get the central vision loss, but also if you were to look at a grid, there'd be lines that are wavy because it's literally being lifted off the rods, lifted off the retina. Okay, so this is the little test you can do. You can say, look at this grid right here, and does it look wavy or not? If it looks wavy, you've got macular degeneration, most likely. Okay, so or you're just drunk. All right, either way. So they have this it's called an Amsler grid. So this Amsler grid is a diagnostic test we can do to look to see if someone has macular degeneration. Also, of course, doing an ophthalmologic exam, looking at a fundoscopic exam, looking at their eyeballs, right? Looking at the back of the retina to see if there's changes. And what other situations like in Med-Surg 1 would you look at the back of the eyeballs? Mm-hmm. Diabetes is a high risk for retinopathy, but also this would lead to low flow, and also ASCVD, atherosclerosis, which diabetes kind of lays the groundwork for, is going to cause is a reason to look at the back of the eyeballs. All right, so you can see literally the grid is misshapen. You can see walking on the street right there. You can see that looks not great, right? And it looks a little twisted, but also the central vision can get lost as well. So if we show you a picture on the test, that would be a correct answer, right? Where the central vision is dark, right? There's no other piece where the other vision disorder where it's the middle is cut out. It might be like hazy if there's cataracts, right? There might be some spots missing. I'm not gonna do that to you. It's like, oh, it's actually cataracts that has has a little space in the middle. Okay, that video didn't play, did it? I'll have to play that video for you guys. Anyways, you have central vision loss and you have this waviness pattern, right? And you can see here's normal. Actually, that's the early stages. Normal's over here somewhere, I don't know. By the way, we have this overdevelopment, overproduction of blood vessels, and then it can lead to this retinal detachment, okay? So which one's the late stages, wet or dry? Is wet. Wet is the later stages. First it's dry and then it becomes wet. Right? The wetness is because is advanced dry. It is because of the overproduction of blood vessels. Okay. So what else? So the Amsler grid, right? That is to see the waviness, right? Tonometry, make sure it's not glaucoma that's causing blindness. And then what else? Fundoscopy. It's just not the examination of the fundus, but the examination of the back of the eye, the retina. Okay, so this overproduction of all these vessels is the underlying problem here. So an example of walking with a filter that has macular degeneration.
So there's a challenge. You walk down the stairs, you skip a step with this thing you gotta look at. My toes looking mad, but you can't see shit. Alright, so I'm a
So fall risk. All right, so treatment for macular degeneration. How do you fix it? There's nothing definitive. There's really no cure. You just slow the progression, right? You can't get new eyeballs. You can get new cornea. You get new lens from a dead person, like legitimately, not like going to China or anything. But you can't get new eyeballs themselves. You can't reattach all the millions upon millions of fibers at the back of the optic nerve, right? So diet, right? There's this AREDS too. Right, this little formula has all these fun extra things, including zinc, right? That's going to provide all the things you need for eye health, and it's evidence-based. It's not like something I saw an infomercial at 2 in the morning. It actually works, all right? And then yeah, the earlier the better. But the other thing you can do is this phototherapy, where they literally, again, shine, not lasers, but what laser stands for, has light also, but this little photoreceptors that are going to, they put a little injection of a chemical that reacts to photos, and it's going to stop that overproduction of those vessels, right, that are causing the separation of this membrane, right? Other things you can do is this anti-VEGF meds, and these meds are going to, well, VEGF is secreted when there's low O2, so you want to stop VEGF from proliferating and being produced. So what we do is we give eyeball injections, right? And the eyeball injections have to be done like every 3 to 6 months. It's like not like, oh, I got one injection, I'm good. You have to get a tune-up every 3 to 6 months, and the cost is like $10,000 to $20,000. It's not very maintainable, right? But these are all going to inhibit the expression of VEGF, right? So it inhibits the DNA RNA production, or DNA RNA that specifically makes VEGF. And we have this aflibercept. That one is going to bind. It's literally you're dissolving a receptor site into the blood, into the eyeball. So you're injecting receptor sites into the eyeball, and then the VEGF is like, oh, look, you look like my VEGF receptor, and it attaches to that, and it inactivates. It reduces the VEGF numbers. It's pretty ingenious. And then monoclonal antibodies we're familiar with. So these guys, you're doing injection into the eyeball, and those will bind to VEGF. Those specifically engineered antibodies, again, made by all the people that, and their first initials and last initials, and their pets' initials of who who discovered it, right? So what is it, ranibizumab, all right? So Randy, right, and Bill and Ursula, they also made, ranibizumab, right? And those are all going to be injected, and they will, the MABs are specific antibodies that bind to VEGF and inactivate it, right? That's the underlying problem here, right? And then we can also do surgeries with lasers, right? That's really for the retinal detachment, and that will also hopefully scar off these vessels that are overgrowing, right? So these vessels will eventually stop growing, hopefully, with these interventions. But again, these are not curative like LASIK surgery. LASIK surgery has a great outcomes for our patients with refractive disorders. But with this one, it doesn't work that great. Okay? And these are super expensive and usually out of reach for most people. All right, so what is this? These are examples of different eye disorders.
So these are a few simulations of how different eye diseases affect vision. This first one here is diabetic retinopathy. This one is cataracts. Now this one is glaucoma. And then finally, macular degeneration.
Doesn't make the wavy lines, but you get the idea. It's central vision loss, whereas which one was peripheral vision loss? Peripheral is glaucoma.